I should say I'm going to focus on urine drug testing in this talk because I think that's what's most commonly used. But what I'm talking about today is really applicable to tox testing in general. So it's really not specific to urine, although that's the term I'm going to use since that's what most people are pretty familiar with. So no disclosures. Some learning objectives. So we don't have a ton of time to talk about a topic that is very near and dear to my heart today. So we're going to be pretty focused in our chat, but I'm happy to answer questions, outside the scope of these objectives. And certainly if something comes up that we want to discuss further, feel free. But this is what I kind of have on the agenda today. I want to be very clear because there has been understandably quite a lot of confusion around this term screening. So before we move forward, you'll see screening already on this slide, several times. What I'm talking about today is called a screening test. And I'm going to try very hard to use those terms together so I'm really clear about a screening test, not a verbal or conversational screen, which is what Dr. Klee was primarily discussing. I wish I had another word to use because I think screening test is a bad term that is misleading, but unfortunately that is the term. And if you call the laboratory or, look up, scientific articles on this online, this is the term that's used. And so unfortunately, we're sort of stuck with that nomenclature right now, but I'm going to try really hard to say screening test and not just screen, because screen is very misleading and not clear. Okay, so with that, let's talk a little bit about what drug testing in general can tell you. So a drug test might, emphasis on maybe, might tell you if a patient was exposed to a particular substance or a class of substances. So importantly, many drug tests cannot tell you about which substance in a particular class the patient may have been exposed to. For example, benzodiazepines. We know there are lots and lots of benzodiazepines out there, and many drug tests cannot distinguish one from another. More importantly, Kaylin, Dr. Klee, I should say, did address this quite extensively in her presentation, so I'm not going to kind of harp on this point, but drug testing many times will not tell you lots of really important things like who, what, where, when, why, all those contextual factors that are much more important, frankly, than the exposure itself. And certainly much more medically significant, right? Just because a patient was exposed to some degree to some substance is essentially meaningless information without the context of that exposure. And certainly, like, if you put all the social stuff aside and think just medically, at minimum, from a toxicology perspective, we want to know something like the dose of exposure, and a toxicology test, certainly a screening toxicology test, will not give you that information. So there's much to be desired here. I think the last point I want to emphasize on this particular slide that, again, Dr. Klee touched on, but I think is really important, and we get called about this quite a lot, is drug testing cannot tell you under any circumstance whether and to what degree a person was intoxicated or impaired. And we get called all the time, basically from people hoping that we have a magical, insight hat that is going to allow us to interpret this and, somehow divine that information. And we cannot. That is not something that these tests can tell you. So I just want everyone to be really clear that under no circumstance is a test going to give you that information. So already I've started to paint this picture that testing is really limited in its capacity to give you information. But I think this is a slide that's really, really important to understand, because when we talk about drug testing, I think a lot of people sometimes conflate these two different types of tests. And it's really, really important to understand, if you're talking about testing, which type of test you're talking about, because they will actually give you very different types of information. And in some cases, one type of test might actually be useful to you, whereas the other test is not, and you don't want to be ordering the wrong one. So tests come in two sort of categories or buckets. There are screening tests and confirmatory tests. Most of the time when we talk about drug testing, most people are talking about screening tests. So when you talk about a urine drug screen, that's a screening test. When you talk about, I should say any sort of drug testing that is going to give you typically a qualitative result, like a positive or negative result, that's almost always a screening test as opposed to a confirmatory test. Most screening tests are immunoassays. So for those of us that are clinicians who are nerdy and remember back in the day, learning about like laboratory techniques and stuff, most of these are immunoassays. And because they are immunoassays, they are subject to numerous false positives and false negatives. And we're going to get into this a little bit more moving forward. But, understand that the idea here is that the company that's making the test, that's making the reagent, is basically creating an antibody that is designed to bind to some portion of the structure of the drug in question. And they can decide basically how good a match they want that to be. And it's a tough thing because on the one hand, obviously you don't want it to be such a poor match that it's going to, bind to 10,000 other proteins that have nothing to do with the drug in question. But you also don't want it to be so incredibly tight and specific that you may be only testing for a very specific, individual pharmaceutical agent when you may want to be testing for the class. So if you want an opiate screen, for example, if you can create an antibody that is extremely specific to morphine, but then it's not going to detect any other opiate, right? So it's this fine balance between wanting it to be specific enough, but not too specific. And unfortunately, that's a really, really difficult thing to do. And as a result, we have tests that are basically not very good at what they're supposed to do. That said, they're used really commonly, as we all know. That's the whole point of us being here, right? And that's in part because they're cheap, they're fast, they don't require a lot of training to use them, and they're everywhere. They're really readily available. That is in contrast to confirmatory tests, which are generally speaking much more sort of fancy technology. So HPLC stands for high performance liquid chromatography. GCMS stands for gas chromatography coupled with mass spectroscopy, and LCMS stands for liquid chromatography coupled with mass spectroscopy. The details doesn't matter. The point is that these are very, very technologically savvy, highly accurate, highly precise tests that essentially, for the sort of purposes of this discussion, don't really have the problems with false positives and false negatives that screening tests do. That's why they're considered confirmatory. They should confirm the result that was sort of presumptively obtained from a screening test. They also almost always will produce quantitative results, which can give you a little bit more information than just a yes, no, present or absent type of result that you get from a screening test. But they are very expensive. They're slow. Sometimes turnaround time for these tests can be on the order of weeks, which is not usually very clinically relevant to people. And typically part of the reason they're slow is that it requires almost always sending out. So most hospitals don't have, gas chromatographs and mass spectrometers sitting in their lab. That's just not something that is going to be used very often. And so most hospitals don't invest the gazillions of dollars that it takes to buy one of those. Okay. So I'm going to take a pause there and I know we're supposed to do questions at the end, but sometimes this does create questions. So I wanted to take a quick pause. If there were like immediate questions on this topic, now would be a great time to jump in. And if not, we can move on.
Yeah, and absolutely no pressure to hold questions to the end. We love interjection questions, and we'll go the whole time of the presentation plus discussion, regardless of when you ask the question.
Perfect. I didn't want to mess up the agenda,
but
you're
good. Thank you, Laura.
Very happy to take questions anytime. Okay, I may move forward, but if people do have questions, just pipe up or stick it in the chat. I can't see the chat very well from where I am, but I'm sure that Katie or somebody else will let me know if a question pops up.
I'll let you know.
Cool. Okay, so as was sort of alluded to in the title of my presentation, urine drug screening tests are complicated to interpret, and they're very nuanced. And I find that often what scares me the most about these tests is that people don't necessarily recognize that nuance and complexity, and they sort of take the result as gospel. Like, it says positive, therefore it is positive, or it says negative, therefore it is negative. And that could not really be farther from the truth. These are really, really complicated to interpret, and they are deceptively complicated, right? Because the result looks really straightforward. There's not like a bunch of numbers, there's not a reference range, but these are much more difficult to interpret, in my opinion, than like, an elevated CRP or something like that. So we're going to talk about a couple of points here in the coming slides. So the first is that what you find depends on what you look for. And I think a lot of people mistakenly assume that whatever their hospital has in terms of its sort of standard urine drug screening test is the end all be all. But that is certainly not true. And I'll show you that in a minute. CrossReactivity, which is what I was alluding to earlier when we were talking about the antibodies that are used in immunoassays. CrossReactivity means that the antibody is supposed to, is designed to bind to drug A, but it actually also binds to drug B, even though drug B was not the target of the antibody. That's what cross-reactivity means. So we're going to talk about how that's a major problem and how that leads to false positives. And the last thing, which I'm not going to delve into moving forward because I think it's a relatively straightforward point, but I want to make sure that you guys understand, is that there is a threshold, so to speak, or in other words, a minimum quantity of drug present in somebody's urine, blood, whatever the matrix is that you're testing, that you have to have in order to make the test actually read out as positive. So you can have a situation where a patient in fact was exposed to drug A, and the test is designed to look for drug A, and the patient really does have drug A in their urine, but they have drug A in their urine at a concentration that's low enough that the test will not read that out as positive. It's going to read it out as negative because it's below, I'm making up numbers here, but it's below 100 parts per million or something like that. And that threshold amount varies from test to test, from brand to brand, from hospital to hospital. So you can have the exact same sample run on different assays and get different results, which is scary, right? So I want everybody to know that and internalize that, and the fear that should hopefully instill in you when you're trying to interpret these, because you're making big time decisions on information that's not very complete if all you have in front of you is just this little piece of paper. Okay, so let's delve into these top 2 points a little bit more so you guys see what I'm talking about. So what you find depends on what you look for. I mean, again, this is sort of like an obvious statement, right? But I think a lot of people don't realize the diversity of testing options that are out there. So what I've listed here are the 3 hospitals where I see tox patients clinically. And I can tell you as a medical toxicologist that anytime I am consulting on a patient and the provider says, well, I've ordered a urine drug screening test, so you'll get those results soon, I would say more often than not, maybe even the vast majority of the time, I will sort of curiously ask, why are you getting a urine drug screening test on this patient? Because the bottom line is half the time the results are garbage. They're just not useful to me. I have so many other things in my arsenal of information that's much more valuable to me than the answer to this test. And certainly at certain institutions, so at Denver Health, you can see, for example, their sort of standard urine drug screening test has only 5 target analyte groups, so 5 sort of, topics that it's testing for, so to speak. And as we'll see in a moment, a lot of these are subject to tons of false positives and false negatives, such that I don't really care what this tells me. It's just not going to give me anything very valuable. Even if something comes up positive, I'm going to question if it's real. If something comes back negative, I'm going to question if it's real. So why would I bother sending that test, right? Now you can see at Children's, for example, they have a much more robust standard, air quote standard, meaning like the default option. If you just type in like a urine drug screen test, this is what's going to come up. And part of that is because the sort of pretest probability of something being positive in a toddler is very different than it is in an adult. And so we are in many respects a little bit more willing to tolerate the nuances and frankly not very accurate results that we get from these tests, because In a young toddler, sometimes we don't have a lot of other information to go on, especially if they don't come with a historian with them. They're not going to give us a history. And so we're sort of, flying blind and really looking for information anywhere we can get it. But as Dr. Klee mentioned, anytime we get a result back that we, for whatever reason, are concerned about or question, we follow it up with a confirmatory test, because we know that the results from this original screening test, there we go, the results from this original screening test are in and of themselves not particularly useful. So unless you are prepared to follow up whatever urine drug screening test you're going to send with the confirmatory test, I would hesitate to send the screening test in the first place, because it's not going to give you what you want to know. And if you're planning on sending a confirmatory test after every urine drug screen that you order, I would hope that you're not ordering, dozens of these every week, or you're going to get a call from the lab because you're sending a whole lot of expensive sendouts. This should be something that in sort of best practice is very selectively applied. And sometimes that is totally appropriate and should be, obtained. But it should not be a sort of shotgun approach to patient care. This is a big deal. So this is, again, just a snapshot of how diverse hospitals can be in terms of what they offer in terms of their air quotes standard urine drug screening test. In addition, let's talk a little bit more about cross-reactivity and what that means and how this can be so problematic. So again, what I'm talking about here is when the makers of these tests are creating these antibodies that are, again, designed to bind to a particular drug, we call that the target analyte, meaning the target that the test is supposed to be looking for. To give an example, as I mentioned before, opiate screens, often many makers of opiate screening tests, I should say, are targeting morphine as their target analyte. So they are designing an antibody that is going to bind to morphine, and you can see the structure of morphine there on the left. The thing is that there are lots of other non-morphine drugs that are similar enough in structure that most of the time those antibodies will also bind to those similar structures. So as an example, you can see the structure of hydromorphone, which is dilaudid, next to it. And it's really similar, right? It's really just at the bottom here. I lost my cursor here. Right around here that you see a little bit of change, right? But otherwise, those structures are nearly identical. And so most of the time, many times, the antibody that is designed to look for morphine will also bind to hydromorphone and will create a positive if there's enough hydromorphone present that it exceeds that threshold that we talked about that will make the test read positive. However, an antibody that is designed to look for morphine is almost certainly not going to bind to fentanyl. And you can see why. The structures are completely different. There is no homology there. They are not the same, even a little bit. And so it doesn't really matter how bad of an antibody, so to speak, it is. There's just no similarity there. It's not going to bind. And fentanyl, as Dr. Klee said, is one of the major problems we're seeing right now in terms of substance use in Colorado and actually across the country. And yet, none of the tests at these 3 hospitals are going to see fentanyl. So that's a big problem, right? If that's one of the most common substances that people are going to be exposed to that has a medical implication, and we can't see it on the test that we're sending, that's not great. So similarly, you can have a problem where a patient might be taking a medication therapeutically as prescribed, but it is similar enough in structure to the target analyte that a test is going to read positive for example, amphetamines, when in fact what the patient is taking is their appropriately and normally prescribed ADHD medication, which many of them share the same amphetamine backbone as the target analyte for most of these screens. So this can be sort of a double-edged sword and very problematic in that the cross-reactivity can both give you lots of false positives, and the lack of cross-reactivity across opioids, for example, like I've shown on this slide, can not give you a positive even when there is in fact an opioid present. So here, I want to even go deeper into this kind of problem and demonstrate to you that it's not just about the individual molecular structures. It's also about, like we talked about, how exactly the makers of these tests design the antibodies. In other words, how tightly do they want this to bind? How precise do they want that antibody to be? Because like we've talked about, if it's too precise, you miss things that you don't want to miss. But if it's not precise enough, then you get too many false positives. So this is, the numbers don't matter here. This is just to show you sort of visually that across brands, so Cedia and Seva, these are different brands of makers of basically urine drug screening tests and also the reagents that go in the test. So they're basically the people making the antibodies, essentially. They can and do have pretty significant differences across these different sort of testing platforms in terms of the cross-reactivity. So what you're seeing here is specifically for the amphetamine screen. And you're seeing here that there's lots of drugs that have some amount of cross-reactivity with a true amphetamine, which for those who want to be really nerdy is a phenylethylamine backbone. That's the structural backbone. So these all have some phenylethylamine backbone component, but only some of these are actually amphetamine, right? So L-amphetamine is amphetamine, D-L-amphetamine is the racemic mixture of amphetamine, and the rest of these are not actually amphetamine. They are just analogs of amphetamine. And you can see that there's a wide range of cross-reactivity across not just in individual, like one column, how much one particular drug may cross-react with the amphetamine screen. But even you can see, like, for example, pseudoephedrine or Sudafed at that bottom one on the last line. For the Cedia systems, that's not going to cross-react. But the Seva system is going to see that exactly the same as amphetamine. And so this is what I'm talking about, where if you take the exact same urine sample of a patient that took Sudafed that morning, and you run it on a Cedia platform, that's not going to be positive for amphetamine. But if you run it on a Seva platform, it will be positive for amphetamine. And that is a big difference, right? So we want to be really, really careful about how we interpret these tests. Okay. This is my last slide, which I will probably nerd out for a while, but just so you guys know, we're in the home stretch here. And then hopefully we'll have some time left over for a little bit of discussion. So this is in no way, shape, or form a comprehensive list. In fact, I had to pare down my already not comprehensive list substantially to make it fit on the slide and still be legible. This is a very, very tiny little bitty snapshot of a few things that can cause some urine drug screening tests to be falsely positive, some of which we've talked about already. So like ADHD medications and decongestants causing a false positive amphetamine screen. We've talked a little bit about, actually we haven't in this talk, but a lot of people are aware of the fact that TCA screens are notoriously pretty bad at actually detecting, TCAs and TCAs alone. And there are lots of other drugs that can cause a TCA screen to be positive. But I want to point out some that a lot of people don't know about. So first of all, there's a common myth out there that cannabinoid screens or screens for a THC metabolite are extremely specific, and that they are reasonably specific, but it's certainly not foolproof. So there are regularly prescribed medications that can cause a false positive for some assays for THC. In addition, methadone, I'm seeing this happen a lot at Children's actually, because we have methadone as a target analyte on our urine drug screen, as you guys may recall from that slide a few slides ago. I would say in my time at Children's, I've seen, certainly dozens, if not hundreds of urine drug screens sent. Not infrequently are those positive for methadone, and the number of times that the patient actually ingested methadone was one time. So as you can see, like diphenhydramine, for example, is a common cause of a false positive methadone screen. Lots and lots of people use diphenhydramine, that's Benadryl, and they probably aren't even going to tell you that because it doesn't seem relevant to tell you that they took a Benadryl yesterday. Like, why would they share that with you unless that was somehow relevant to their chief complaint? So unless you're taking a really thorough drug history to include over-the-counter preparations, supplements, so Ma Wang is on here, for example, as a reason that amphetamine screens might be positive. But there are tons of other supplements out there that can cause various drug classes to be positive on a screen. Not to mention that in the US, supplements are not regulated such that you in fact have no idea what you're buying, and sometimes maybe purchasing something that you did not understand you were going to be taking. This can become very difficult to interpret, right? And so I hope that I have convinced you guys that just because a urine drug screening test says positive certainly does not mean that the patient in fact ingested or was exposed to a drug in that particular class. And on top of that, because again, I had to cut this down to make it fit on the slide, I didn't even include on here all of my false negatives. But there are so many classes that may not actually show up on a urine drug screening test, even though you want them to. We've talked about how that can happen with opioids, particularly synthetic opioids like fentanyl. They are not going to show up on your opiate screen. Another really big problem child with that is benzodiazepine screens. So many benzodiazepine screens are designed, the target analyte, that thing that the antibody is designed to bind to, they are designed to bind to a particular metabolite called oxazepam, that unfortunately is not actually a metabolite of very many benzodiazepines. So lots and lots of benzodiazepines that people use all the time, like alprazolam, for example, which is Xanax, that's not going to show up on many brands of a urine drug screening test that uses that particular target analyte for their benzodiazepine screen. So again, you are really risking getting information that's not particularly useful to you. And I hope I've, sort of demonstrated that given how complicated this is to interpret and how much sort of uncertainty there is in these results, you are so much better off talking to the patient and sort of going down the pathway that Dr. Klee set out for you to get much more robust information that is way more reliable, frankly, than what this is going to tell you, unless you're planning on sending a confirmatory test after every single one of these. And I think that approach is much more likely to reduce harm, because you can see how much harm you're going to cause potentially by getting particularly a false positive. Even if you ultimately end up confirming that it's not a true positive, that's going to take potentially weeks, as I've already told you. Confirmatory tests can take a long time. And that patient is going to be pretty scarred by that experience, I would imagine, right? By the time that gets sort of sorted out, a lot of times social services is already involved. Sometimes there has already been a removal, which is problematic. Not so much in the neonatal period, but this happens sometimes with older children. And we want to be really, really careful about understanding what the repercussions of this can be, particularly if a confirmatory test has not been sent or hasn't resulted yet. So I'm just rambling at this point. I'm going to zip it and see if there are questions or comments or thoughts that we can sort of move forward with. Thank you all.
Lori, this is Jamie, and wow, that was so interesting. I felt like for a minute I was back in organic chemistry and learning about all this. So really, really interesting. And I'm curious, maybe not so much a question for you. You might have some experience in working with the hospitals that you mentioned, but for those on the call, who's interpreting these tests in labor and delivery, and what's their training? It sounds like, you have to really understand what you're looking for and be able to interpret that and then apply that. So I'm just really curious, across the board, hospitals across the state, those on the call, like who's charged with interpretation, and then, next steps based on that interpretation, and how are they trained? And
I
maybe,
would certainly welcome thoughts from anybody on the call. I can tell you in my anecdotal experience, this is a really interesting phenomenon, like nationally. So locally here, anecdotally, it seems like most of the providers that are either like on L&D or on the pediatric side taking care of the babies typically essentially interpret these themselves. There are other places in the country where essentially 100% of these get sent to a medical toxicologist for interpretation, which is just, I don't really have strong feelings about that either way. I think all that matters is that the person doing the interpreting understands what they're looking at. But I do think it's interesting how that has pretty different like regional sort of cultures around it.
yeah, that's very interesting. Lynn asked a question. How can we get a list of potential positives? This is fascinating. I don't think many of us realize this.
Yeah, so I can certainly send out a list of like common ones, but I want to be really clear that these are not exhaustive. And just like, technology advances, labs get different, they may decide to change their particular brand that they're using or change the reagent that goes with that brand. And they don't have to tell you, which is super scary, right? Like every single, and I mean, this sounds sort of intense, but this is my job. Every single time I'm interpreting a drug test, I call the lab and I ask them, what's the brand? I want to see the manual that goes with that brand. Because the manual will have some information about things that the company already knows may cause false positives or false negatives, but it's not exhaustive. It's not like the company is going to test every pharmaceutical on the market to see if there's a potential interaction or what's technically called interference, if there's interference. So the sort of approach that I personally take, and granted, this is the mindset of a subspecialist, and I don't expect everybody to do this. But if somebody is, if you're actually concerned that something may not be accurate in terms of your screening test, there we go, you should not only talk to the lab, talk to the person who's running the actual assay down in the lab, who has access to the manual and can get all that information, but also checking the literature, because people publish this, it's like literally, it feels like every week there's new reports out about whatever, assay, and turns out that, efavirenz in fact does cause a false positive on this particular assay for THC metabolites. And like, no one knew that until somebody figured it out and reported it. So it's a lot more complicated, I think, than people realize, which is part of why I'm really careful about who I think should have one of these tests sent. That said, a really good place to, I think somebody mentioned this, Lisa mentioned this in the chat, a really good place to start and a simple measure is to call the lab, because they are generally more aware than most of the clinicians are, not just in terms of what testing they're using and whether or not there's been a change recently, but also, they have access to some of the like predetermined information as far as known interferences.
So this is Lisa again, and it's just fascinating, and it kind of makes me feel like most urine tox screens are completely worthless, and I'm trying to see, when we would actually get value from that based on the knowledge that you guys have given us today. Is there like a national organization that has ever done a statement about this that could be disseminated to providers to make them more aware of all these problems?
That's a great question. I know that the American College of Medical Toxicology has some information about sort of interpretation of urine drug testing, although I don't know that it's necessarily geared exactly towards, like the perinatal population, which is, I think, a unique population in many respects. I'm curious, I don't know, Kaylin, do you know if ASAM has anything out there?
I mean, I think there isn't, as far as a statement kind of discouraging use of toxicology testing, there isn't that, because they really can serve a true therapeutic purpose for people in treatment, in prevention. I mean, there can be a role for this, right? So there isn't really, that I'm aware of, a statement discouraging use of urine toxicology when it's appropriate, but there is, as you mentioned, a ton of data in the medical literature. I mean, if you even Googled right now, urine false positive methamphetamine, you'd have hundreds of articles, publications, case reports documenting that this is a well-known phenomenon. And then Brandy, as she's commenting, I was just going to chat this, Brandy, you're so, yes, really is that ACOG has, ACOG, I think, has made the strongest statement about kind of moving away from urine toxicology as being a clinically helpful tool for screening purposes, right? So I'm not talking about, and umbilical cord testing, those are the expanded panels. And so those really are much more accurate. So I'm not talking about all testing, but I'm saying for screening purposes, these really are fraught with concern. I will say the other thing I wanted to mention before I'm gonna have to jump off in a little bit, is that the other folks who have a lot of trouble with this are the social services caseworkers that I talk to all the time. They don't have any training in toxicology. And really often when I'm talking with caseworkers, I mean, I have this conversation probably 2 or 3 times a week where somebody's saying, help me understand this umbilical cord, help me understand this urine, this patient's urine. We're going to court this week for a patient of mine with no confirmatory urine testing ever having been completed, right? And so there's really big problems when these tests kind of are done just reactively, and there's not great understanding either in the medical community or in the social services, civil or legal community about how to interpret these tests. And so I talked with some of our local social service caseworkers about like, what do we need to provide them so that they actually feel comfortable managing this data, because they are equally uncomfortable in my experience with receiving these reports. So.
And I did want to just emphasize something that Kaylin just said, which is that there is a role for testing. I don't mean to say that testing is always wrong or never appropriate, but I think that role is much more limited than we sort of have traditionally experienced it to be. And so, I mean, you know, I'm a fairly new graduate myself, and I can tell you, having trained fairly recently, like very much the culture was still that this was a totally reasonable thing to send on like virtually every patient because it was cheap, it was inexpensive, it's not invasive, and what's the harm, right? And there was no training on the harm. So I think that's the bottom line, is that these are very powerful tools in terms of potentially causing harm, and don't always give you the information that you want to receive. And I think that is the nuance that really needs to be part of the conversation, not to say that these are horrible and should never be used.
Yeah, I think that's really important. And for those who are able to access chat, some great comments about what other hospitals are doing, right? Referencing the lab, like we heard Lisa say, some good information there about, Brandy included ACOG's opinion about this. And I think a lot of consideration, right? About when is the right time for screening tests. Lori, I'll make sure I say that correctly. And, you know, when is conversational screening, you know, coupled with that, and how important is that as we think about the process and best practices across all of our hospitals and caring for our patients. So super helpful, super interesting. Thank you both, Kaylin and Lori, amazing content. I know Katie put in the chat, we will share all of these slides and all the pertinent information, resources in our newsletter. So if you haven't signed up, she put a link in chat as well. So we can follow up with folks that way. You'll get the information if you need anything, info@cpcqc.org. We'll make sure you get all of this information in your hands. Any other last minute thoughts before we move on to actually now like applying some of what we've learned today and how we can make some changes in our areas?